Hello, I am Susie Cooper and I'm here to present examination of the foot and ankle. I have here with me Mike and he's going to help me with this today. Hello Mike, how are you?
Hello, very good, thank you.
Have you got any pain at all in your feet
No.
or ankles or indeed any of your limbs?
No.
Good. So Mike as well, and he's going to demonstrate a few things for me. First thing I'm going to do, however, as soon as somebody comes in, so I always look at their shoes. He's come in his office shoes and kindly got change for me, but I look to see if there's any, what sort of shoes they're wearing, because it's quite important for the comfort and for any rehabilitation purposes for people with foot and ankle injuries. But I'm looking really for the soles, particularly around the heel, to see if one side is worn more than the others. His are not too bad. There's a little bit of wear on actually on the lateral side, but very minimal for considering the way he's had out of these shoes. So that's all a good thing to look at first off. So I'm going to ask Mike first of all to stand up and walk for me so we have a look at the gait cycle. So Mike, if you could walk that way for me, that's lovely, and then turn around and walk back towards the camera. Thank you. As you can see, Mike is a normal gait cycle, and come that's fine, Mike, come and stand over here. If I can have you standing facing the camera, I'm having a look generally to see if there's symmetry of his legs, particularly the knees, as any varus or valgum, which would be of course affecting the feet. We're looking at the ankles. Is he standing symmetrically, which he is, and he may be very slightly pronating there, but only very slightly, but it is symmetrical. I'm looking behind. If you could just turn around for me, Mike, and look at the feet from behind. At this point, I like to ask him to stand up on tiptoes for me and see that he's able to do that. Good. And then if you come down again, Mike, and I'm going to ask you to walk forwards on your tiptoes for me, please. And can you walk forward on tiptoe? That's good. So that's testing his ability, his Achilles tendon, integrity of Achilles tendon, gastrocnemius and soleus. And then I'm going to ask him to walk on his heels, which of course is testing the anterior compartment, as well of course as proprioception and so on. Lovely. I'm now going to ask Mike to lie down on the couch, and I'm going to have a further look in detail at the feet. First thing I'm going to look at with his feet is what's the integrity of the skin? Are there any disease processes going on that would be suggestive of abnormalities such as diabetes, poor skin, loss of hair on the legs, and other neurological disorders which would affect the feet? So there would be asymmetry of muscles, of course. Talipes, for example, would present with foot and ankle complaints. But he's got symmetrical musculature, his skin is intact, there's no obvious calluses or blistering or untoward findings on the skin, and I would obviously compare like with like. I'm now going to palpate, feel the skin, feel for the temperature on both sides, and it's the same. And I'm also going to feel for the pulses for posterior posterior tibialis and dorsalis pedis pulses, which is intact. I'm then going to continue the examination by feeling the fibula, the lateral malleolus coming round, and palpating the three ligaments, the lateral stabilizers. So the ATFL, anterior tibio-fibular ligament, the CFL, calcaneofibular ligament, and the PTFL, coming round the top of the foot, from the recess round to the talar dome, and which is not tender at all, is it, Mike, when I do any of this? No, good. Round to the medial malleolus and the deltoid ligament complex. That all feels satisfactory, and I would compare like with like if there were concerns. Moving down, I'm going to palpate the metatarsals, each individually. There's no tenderness at all there, Mike, when I do that. And the toes themselves, I'm going to gently move them to make sure that there's no tenderness, warmth, swelling, and so on. Particularly the first metatarsal, the MTPJ, feeling for crepitus, typical of osteoarthritis or other disease processes. I would do the same on the other side. Feeling the bottom of the foot, feeling the arches, and just checking as I go past the insertion of the plantar fascia at the calcaneum, feeling there for any tenderness that might be elicited, not tender at all, Mike, and feeling the calcaneus and around the heel and the Achilles itself, although we'll come on to that in a minute. So I would compare that side obviously. So having completed that, I now want to see Mike's range of movement. So I'm going to ask him first to bring his toes up towards him, checking for dorsiflexion. His dorsiflexion is slightly limited actually. I think it's slightly reduced. Should be a little bit more than that. Probably should be about 30 degrees, 20 to 30 degrees. So dorsiflexion is testing his anterior compartment muscles, tibialis anterior, and also plantar flexion. Point your toes down as far as you can, Mike. That should be about 50 degrees. I think it's a little bit less than him. This, of course, is testing your gastrocnemius and soleus. I'm going to ask him to move his legs to the side. That's good. And the other way for me. So internal and external rotation. And then I'm going to ask him to invert, all right, that's eversion. Everting his toes towards the middle. He's got quite a reduced range there. I'd expect a little more than about 15-20 degrees there. But that's testing again the anterior, the inversion, and then inversion this way is testing his tibialis anterior, but eversion that way for me, Mike. If you can do that again, that's testing his perineals. So we've seen him move. He's a little bit stiff, but I don't think it's symmetrical and probably normal for him. I'm now going to move them, if that's all right, Mike. So I'm going to gently dorsiflex his foot. He gets a better range of movement with that. Plantar flex it, move it internally and externally, and then inversion and eversion. I'd like to make sure he's got full power. I'm going to ask you to resist those movements, Mike. So bring your toes back towards you and stop me pushing them down. Lovely. And then I'm going to ask you to push down and stop me pushing your feet back. Good. So resisted plantar flexion. I want you to stop me pushing into the middle. Good. Pushing you out, sorry. And then I want you to push out against my hands. Good. Now I want you to turn your feet outwards, and I want you to try and stop me pushing them back in. Good. Can you do that again for me? Good. So he's resisting inversion. And now I want you to evert your feet. That's it. And I want you to try and turn them out and stop me. Turn them back to the middle. So keep them in. Let's try that side. Keep it in towards the middle for me. Good. And let's try that side. Keep it in towards the middle. Good. So he's got good power there. So he's got a fairly good range of movement. It's certainly symmetrical in all directions of the foot and ankle. And now really the next thing to do is to move on and do some more special testing before I turn him over to look at the Achilles tendon. So one of the most common problems with the feet will be, as I've already said, the MTPJ and osteoarthritic complaints, and we've tested for crepitus there. Another one is Morton's neuroma. That can be by palpating between the digits. One could feel possibly an abnormality there, a discomfort, but by the squeeze test, and you look at the patient to check they're not hurting. Does this hurt at all, Mike? That may be positive if there's suggesting a Morton's neuroma. Moving up higher onto the ankle to test for the stability, we do the anterior draw test. So that I'm simply going to take the leg and check that there is no laxity when I'm drawing forward on the calcaneum. If there is, I would compare like with like. The other test to do, of course, is is testing for the ATFL. Another ligament, of course, which would be the first lateral ligament to go in a significant sprain or injury to the lateral ankle. The next ligament would be the CFL. So by testing resisted inversion of the foot, we're therefore going to be, that will be suggestive of there's further damage. So, by testing forcing him into inversion. So how does that feel if I do that? So there's no laxity when I do that. So it does suggest, and again you can compare with the other side, that his lateral ligaments are intact. To test the deltoid ligament, one would force him into an eversion, and that equally is not painful for you, is it, Mike? No. Okay. So we've tested for the ligaments there. The next one to be thinking about is a syndesmosis injury. So to do this, to test for this, one would squeeze the tibia and fibula, which if it elicited any pain, one would be suspicious of that. And further testing by dorsiflexing and adducting the foot like this will also put pressure on the syndesmosis, which doesn't seem to have any elasticity, again comparing with the other side. So having done those tests, the only other thing now to look at is the Achilles tendon and also the actual range of movement of the ankle. So Mike, if I can get you just to roll onto your tummy, and I'm looking at, this is a good way to, obviously, you can either do this like this, or you can ask him to kneel on a chair, depending on the age of the patient. If they're slightly older, not that Mike's old, but slightly older, one would do it on ask them to lie down. But if they're younger and capable of just kneeling on a chair, that's just as easy. So I'm looking at the calf muscles again, and the Achilles tendon, palpating the Achilles tendon, and one way to look for problems with the Achilles is just literally to see that there is no laxity as you push down on the feet. If there's a ruptured Achilles, one of the feet would be much more flexible, would it be at less of an angle than it is at the moment. Ultimately, if I am suspicious, I can do a squeeze test. I simply squeeze on the calf there, and this causes the foot to plantarflex. So I'm pretty happy that his Achilles tendons are intact. And there's only one more thing to do, Mike, if you'd like to get up. I'm going to get him to come over to the wall, and I'd like to see the angle, the range of movement in the ankle. I've got a tape measure here. We're going to look at his left leg. So he puts his weight through the left leg and starts with his toes quite close to the wall, not making sure that his knee is in line with the second toe. And he's just leaning forward to put his knee onto the wall without raising his heel. As you see, Mike's a little bit stiff. If ideally, he'd come a little bit further away, and we see, but if you try that now, if you lean forward for me, with that foot, it doesn't matter if the heel comes off, you see the heel raises, and that's not ideal. So you then measure, if you bring your foot in further, the distance from the wall to Mike's toe, and of course that's a good way of comparing on both sides and monitoring any change, because we could work on the flexibility of the heel. So all in all, that completes the examination of the foot and ankle.